Great. Welcome, everyone, and thank you for joining us today for the meeting of the New York City Health and Hospitals Finance Committee, the last meeting for a long, productive day. Today's meeting is officially called to order. I would like to propose a motion to adopt the minutes of the Finance Committee meeting held on May 9th, 2022. I will poll each member for their vote. Jose Pagan,
Yes.
Dr. Katz,
Yes.
Sally Hernandez Pinheiro,
Yes.
Fenioski Peñamora,
Yes.
They're voting. Wait a second.
Dr. Patricia Martone,
I guess they
Yes.
skipped over me.
and is Miss Lowe on?
I'm on. Thank you.
Hi, Barbara, and your vote?
Yes, please.
Great, thank you. So the minutes are adopted. Next on the agenda today, we have a financial update on the system. I'm going to turn it over to
I'm
John
not
Alberg, the
actually in
Chief
before,
Financial Officer.
but
I'm sorry, is there
I got started before.
background noise?
There is.
Could everybody please go on mute if you're not speaking? Thank you. John, are you, I can't see the room there. Okay, terrific. Thank you.
Hello. Nice to see everybody today. Thank you very much for your time. As Frida said, we're just going to give a report. We thought what we'd do is start off with, how we closed the year. We closed very strong and feel good about that. Then we'll pivot over to the FY23 budget development. We'll talk about, T2 a little bit, and then Linda has some information financing issues. So that'll be our agenda for today. So we finished the year very, very strong. We have over 500 million in the bank as of today. Our budget variance was a positive $270 million. So we outperformed on the budget almost a full 2%. So that was good. And as part of that, we've gone through and done our accounting, and our credits and liabilities pretty much balance out. So the 270 is a pretty solid number. One of the things that we've looked at together, which I always find impressive, is just how the patient care receipts are performing on an actual basis, not against the budget, but performance year to year, actuals to actuals. We're up another $550 million. I think last year we were over 450, maybe coming close, about to the same number. So that the revenue performance continues to sustain. And that's a good sign. On patient care volume, we're coming back. We're still 4% below, but the hospitals all report that they're, very busy, day in, day out busy. For the most part, I think our staffing is good. Certainly nursing is reporting that they have an adequate, complement of staff. Strategic financial plan, again, performing very well, $691 million. Through April, and we'll talk a little bit more about that. Next slide, please. James, you want to go to the slide?
Sure. So as John noted, we did end the year well with cash. So we had closed March with about $375 million, which was a little bit lower than we're used to having, about 16 days cash on hand. But as we came into June, we were able to work to get some supplemental Medicaid funds and other funds to close June with about $700 million. We're still, of course, closing the books on June as it just passed, but $700 million was right below our financial plan target and 30 days cash on hand, which is quite strong. In addition, we were able to pay off all of our prior year liabilities to the city, and we do work with them on our current year FY22 liabilities and ahead as we just deal with other supplemental receipts coming in. So we'll continue to do that, but we definitely feel strong about the cash position as we enter FY23. We can go to the next slide.
Yep, managing risk. I mean, this is the same list of risks. FEMA, I will say, I think FEMA is keeping pace with us. We've been getting the approvals that we've been looking for. We are working out some processing issues between OMB and DSHS. DSHS is the state arm of FEMA in essence, and that's where the packages go next. So we're working through a process there. It'd be my goal as we get towards the end of the summer is to hope to get this off our risk list. I think we feel pretty comfortable with the pace of FEMA. Wage pressures, inflationary costs. I mean, inflation has been and will continue to be over the near term, a pressure on the economy in general and certainly within healthcare. But, we took steps in the budget. We'll go through some of the assumptions for the FY23 budget, particularly for OTPS. We built some inflationary cost protection in. We'll have to work with OMB and the city as we look at staffing and wages, going forward. Staffing models and development. We continue to develop out new staffing models, right, to meet basically industry standards. And we've done a lot of work within nursing, have a little bit more work to do there. Behavioral health, called Behavioral Health 2.0. We're doing considerable work there, looking at how to supplement, particularly in the inpatient area, staffing and staffing models, radiology and hospital police, other areas, and there's a handful of others. But staffing models tend to cost us more money. They don't necessarily generate more revenue, but we are working those into the plan as we get them, completed, and we'll build them into the budget, throughout the year. Next slide. So,
Hi, I'll go through the financial performance side. It's Selima Tyler. So as John stated earlier, we did end April with a net budget variance of 2%. Again, driven largely by receipts exceeding budget. Again, against budget, we're $689 million above budget. Again, that's largely driven by inpatient and outpatient volume coming in higher than budgeted, along with the average rates and collectability coming in higher than we initially anticipated in the budget. Add to that the fact that risk pool came in higher than budgeted as well because of anticipated prior year excess medical revenue that came to us this year. On the other side, we have disbursements exceeding the budgeted target by $119 million. Those costs include vax mandate, some COVID and temp coverage costs. We can go to the just to go a little deeper on the revenue side, some drivers of the budget variance more specifically. As stated earlier, our cash receipts are 10% ahead of the budgeted target, largely driven by increased volume. That's contributing about $257 million of the overage, and then higher than collected rates. Again, this is against the budget of $216 million. Risk pool and timing, $97 million ahead of the budget target. And then we have some other revenues that came in that were unbudgeted, largely direct medical education, that's the DME, and Medicare appeals that came in that were unbudgeted. We can move forward. On the expense side, we do have higher needs due to COVID and staff vax mandate that are driving the budget variance. Our COVID emergency spend is right at about $158 million. 66% of that spend is largely on staffing, including temp costs and other areas of nursing and credentialed providers, We have vax mandate staffing at $42.4 million. And then we also have non-COVID spend attributable to volume increasing and back to pre-COVID levels. And that includes temp spend as well as other discretionary. And I don't know, Micheline, if you wanted to add something about the temp spend there.
Yeah, I mean, basically for our agency patient care temp, we're starting now to see the cash payments materializing for the Omicron surge. So we're looking through that as well for the 241. So there's a component here that's COVID and non-COVID. And
right.
Discussion. Go ahead. Okay.
Okay. Sorry.
Sure. So our next slide here is just a quick update on where we stand with our strategic initiatives. The last time we had the update through February. We have a couple of months now in, which shows good progress. We're all in the green now. Last time there was a piece that was in the orange, so all the results are in and showing we're basically tracking towards and ahead actually of the anticipated target cumulative over the full net financial plan target for 22. So you see all the components in there with our growth initiatives, our 340B, our revenue cycle, obviously, our system efficiencies, where we have some components in the ITS, supply chain across, and then our value-based initiatives as well. So doing well so far as we're talking on financial plan.
Can I ask a question before you move on?
Sure.
Yeah, just on the overtime figures, the $241 million, that was primarily for temporary staffing to deal with Omicron? Because you also talk about the staffing up to staffing models. Are those two different costs, or this is just overtime to cover the Omicron issue?
Right. So the 241 is agency temp staffing, and it includes Omicron, but also includes us right sizing in our non-COVID area as we basically get back on track in terms of the components that should be temp agency and full-time. So we're supporting our regular operations using some of that agency temps until we get up to our models on the full-time side of the world. We recruit and we hire up. So some of this is help to get us up to our full-time side of the world, up to those models.
I got you. Thank you.
Great, thanks. I'm going to ask, just so we can get through all the materials, if we can do questions at the end. It's okay. Thanks.
Sorry, Frida.
That's okay, Sally. But just to keep us going. Thanks.
Okay. So for our next fiscal year, so we have gone through our cycle of budget development with our strategic priorities there. So the focus for this fiscal year, just as we were just talking about with our models, is basically implementing our staffing models across the different nursing areas, implementing the workforce plans, including the provider workforce plan. There is the value-based and ambulatory care components, and the core infrastructure and rebuilding for the future. So in this one, we are basically looking at our staff in relation to those core services in particular, so behavioral health, radiology, peri-op, and anesthesia. Also, we have capital projects that are basically that were recently granted, and we're connecting that to make sure it's connected to our system-wide strategy and our growth initiatives there. So there is an alignment between operational and our capital side. We're looking at pharmacy for fiscal 23 and going forward beyond that. And we also have multiple cross-facility and cross-department initiatives. And of course, with revenue cycle, we continue the efforts and the improvements there.
So this is Matt Sigler. I'm happy to jump in for a couple slides here. One of the anchors of our financial success in the past few years, and really a major part of our future, is value-based payment. We've talked about it with the board before. You've seen a version of this slide, but this is just an update on our performance. We continue to see growing attributed membership, both across the main lines of business and in the key specialized programs like HIV SNP and the Health and Recovery Plan that really offer enhanced services for our members and enhanced potential premium revenue for us and our health plan partners. We've got a lot of initiatives underway to grow our risk surplus and improve the quality of care and boost our quality bonus payments. So we've seen great success in those areas, and we'll try to keep you updated with a version of this chart at each finance committee meeting. And then the next slides just go into a bit more detail about specifically what have we done, what drives these results. Not all of it is as glamorous as you might expect from me, but it's all very good and important. We have a centralized outreach team that is reaching out to tens of thousands of members all day, every day, to try to get them in for key visits to help them close gaps in care. We're one of the first systems, if not the first system, I believe, in the whole country to use our MyChart app to message out to individuals to try to get them in for some of these key value-based initiatives. It's just not a tool that folks have used for surveys and things like that the way we have. We do supplemental data exchanges with the managed care plans. It's a really kind of rigorous process to get all the information in so that we get credit for the work we've done. We have a homegrown tool called the Care Gap tool that our ambulatory care team and managed care team work together on to push out to all our facilities to make sure we're closing all those key gaps in care across the multitude of quality programs that we have in our different health plans. And then, we have really built a community around this through program support. And then there are kind of key initiatives like an eye camera that we've added across 15 sites that really improves the eye exams and improves our diabetes care performance. So some highlights of the key actions there. And then on the next slide, we have some of the exciting results from one of our biggest health plan partners. So Health First is partnered with most of the major hospital systems in New York City. And one of the great things about their quality program is we see how we measure up against other hospitals and health systems in the city. And so it's one thing to say we deliver great quality as a health system and great quality at a great value. But when you look at some of these measures that we outperform the rest of their network on 93% of the Medicare measures, that we outperform their network on 2/3 of the Medicaid measures, that really means that we're not just above average, but one of the leaders in the city in terms of the quality of care we're able to deliver to this patient population. And so that's really incredible. And several of our facilities were the highest performing in the entire Health First network. So we're really pleased with the improvement here. We want everyone to be high quality, but we are always proud when we stack up really favorably against our peers around the city. So wanted to share that with you all as well. Next slide. All right, back to you, Margie or Michelle.
Thank you. So we wanted to highlight that for fiscal 23, the revenue cycle initiative target grows by about $50 million on a gross basis, from $454 million to just over $502 million. And what I think is significant about this, when you look at each of the individual activities there, is that we're really focusing on optimizing our internal workflows and reducing our reliance on vendors. So as an example, that very first initiative up top, accounts receivable, that decreases by about $30 million, that target, and that's really vendor-driven initiatives. Whereas the administrative denial reduction, the next line down, increases by $47 million. And that increase is really driven by our expectation and our target of moving from our current median performance. We're about median as compared to all of Epic's customers. We benchmark against a cohort of Epic customers. And our plan is to move to the top 25% by fiscal year end. And that's really by optimizing and improving our internal workflows. Similarly, with ensuring the uninsured, that's all work that we're doing internally. We've increased our financial counseling rates, and we're looking to push that further.
Okay, I'll talk about Test and Trace. Just to start with our normal financial update, we are currently projecting that FY22 spending comes in around $1.36 billion, and we're projecting FY23 to be just under $200 million. We committed about $226 million in the final quarter of FY22. And, as always, OMB has continued to provide sufficient revenue for T2 spending through the MOU. We don't have a slide on this, but I did want to give a quick programmatic update. T2 very recently rolled out a new program called Test to Treat, and this builds on our existing mobile unit infrastructure, but it's the first program of its kind providing not only access to rapid testing, but also access to get a prescription to Paxlovid on site. So T2 currently has 30 mobile units throughout the 5 boroughs, providing this access to New Yorkers, and we hope to be able to surge up if that's necessary with future caseloads. And as far as testing strategy overall, T2 is kind of looking to focus more on, rapid testing access to try to meet people where they're at. So doing that through these mobile units, but also through a number of community distribution sites.
Great. I'm sorry, did Micheline or does somebody want to go through this slide too, or
Sure, I
no?
mean,
This was just the appendix. Okay, go ahead.
yeah, it's in the appendix. It just continues basically our to show the progress, focusing specifically on the revenue side of the world, with actuals to actuals and also actuals to our budget. So John highlighted that, and Salima also highlighted our budget piece of it. This just shows a little bit more on some of the drivers when volume is mentioned. So there are the discharges that are up by 13.7% and our visits slightly down, but basically the discharges are driving a good chunk of our dollars, especially when we compare to particularly when compared to the pre-COVID times. So this big picture here.
Okay, great. So I think we're going to pause here, and why don't I take questions from the members before we get to Linda's informational item? So thank you everyone for a really great update as always. There's always many challenges you guys are dealing with, but all of this is really terrific outcomes so far. So why don't I start with Jose?
Just a great update. Just praise for hitting the quality indicators on quality that I could comment on a lot of things that happened in the presentation, but that one is really important that we're hitting quality targets and sharing data and being the best in the city. Thanks.
Thank you. On this, actually, just before we move on, I'll hold my questions, but I think, Matt, it might, I know we've often tried to talk about this. We run out of time usually, and we don't have an ability to get into our value-based performance and these quality outcomes. But Jose, I think it might be nice to perhaps have an informational item at one of the board meetings, just to, I know you'll continue to update us in finance, but maybe just once, it doesn't have to be the next meeting, but I don't know what you think about that, Jose.
Yeah, definitely. Particularly as it impacts not only quality, but also, of course, revenue.
The finances.
Yeah.
Right. So perhaps we can work that in for one of the full board meetings.
Happy to. That'd be great.
Okay, great. Thank you. I'll move to Sally.
I have two questions. I know we're up to, I think, 2 finalists in the coding audit that's going to be done. We don't have any anticipated savings included in your current projections. Is that right?
That's correct. We didn't capture any additional revenue capture or savings based on what's still a little bit of an unknown at this point.
Okay. And my second question, just related to the connection of capital projects, is that referring to capital projects that'll have some kind of positive revenue impact? Is that the correlation with capital projects? I'm sorry, I don't have.
This is Matt.
Yeah,
I can speak to that. I think we have many high priority projects. They do have an impact on our revenue. I also think they have an impact on our expense dollars, right? I mean, the sheer amount of temporary work we do, recovery actions we take when infrastructure falls down. As I'm working more closely with Manny and Oscar and Menji, we're trying to integrate them, more closely into our financial planning on the revenue side and the expense side. So that's what we're thinking about here.
oh, okay, thank you, Matt. That's it.
Great, thank you, Sally. Fenioski.
Yes, again, thank you for the report, and I want to echo Jose's comments in terms of the quality indicators and the performance compared to peers. So kudos to everybody in the team. I just have a question. If we go back to the expenditures of COVID expenditures, I forgot what slide it was.
The drivers.
No, the one that has 6%.
slide 8.
Yeah, this one. So let me see if I understand this slide correctly. So we are over budget by 419. Is that what this slide is telling me? 419 million or?
Yes.
So
Okay. And how are we going to make up this? Are we expecting to make up this in the next year through the improvement in how we allocate funds, or the system will have to cover that?
So in the 419, oh, sorry. Can you hear me? Okay.
Now I can hear you.
Okay, sorry about that. In the 419, because this is cash-based, so there is a timing aspect in there, so it includes a good chunk of dollars in you see in the first line, which is the 158, and some portion of the 241 that's associated with COVID and Omicron spend, which as we receive more federal dollars, in terms of our financial standing, it will fill some of those gaps as we draw down more of our claims.
So in that case, we don't expect this we have a deficit on this. This is what I don't understand. I understand that there is a timing issue,
Right.
but maybe when we report, we can report today, but also we report to the end of the fiscal year. Where are we
What
going
we're
to be
anticipating.
when we come in with all the revenue? Again, and Frida knows more about this issue of finance, but just to have a clarity of where are we going to end up at the end of the fiscal year? Because our fiscal year is starting July, or
Yes.
when is, yes,
July 1,
July 1. And this is report as of
April
when?
30th.
April. So in that case, next report, we should be able to zero out. Is that correct, or
Yeah.
I'm missing something?
So there are two things, right? So this looks only at the expense portion of it. So our revenue performance also being ahead of our budget is filling some of those variances that you see on the expense side, and that's why the net margin is actually in the positive. So yes, when you look,
I'm sorry, it might be helpful to turn back to slide 6. Back 2 more.
yeah.
Yeah, Finney, I think you have to look at the two
Yeah.
slides, the revenue side
Right.
and the expenditure side, and we're just trying to do a breakout. So maybe we look at the revenue,
Right.
right? Yeah, go ahead.
Right, so that's what I was referring to here, like the net revenue, basically, we are doing 689 better than originally anticipated, and on the disbursement side, so it offsets that 200 against the negative 419 on the disbursements. And even on top of that, those disbursements also include COVID dollars in there that I was just referring to earlier from a timing perspective, where the federal dollars have not been drawn down yet, but we're anticipating hopefully to get those eventually from FEMA.
So on the next slide, Finney, you can see the breakout. It's a similar companion slide to the expenditure slide, where we're showing the components where we're 689 or 10%, right, better than budget on the revenue slide. When I look at the next slide on the expenditures, right, my takeaway is setting ourselves up for next year. If you go to the next one, the expenditures in my mind are like related to COVID or something that we can manage, right? They should go away, right? So again, when I'm looking at this in the context of next year's budget, I think we look pretty good. The agency patient care temp staffing, right, obviously more expensive than our own staffing, and we're trying to manage that down. So I think when you look at them both in context, A, we did better than the budget by 250 because the revenue was strong and it looks to be sustaining. And going forward, I think we can manage these expenditures where we were over.
Okay.
Carry them forward.
This is very helpful, but I don't know, maybe we should also talk about the net, for clarity. But in this case, our net is going to be positive. Is that money going back to the feds, or do we keep that net positive?
We keep the net positive. That's our money that we've earned. Our plan is to keep that money. Yeah.
Okay, but and do we have flexibility to reallocate that money across other services, or we can only use it for COVID-related initiatives?
We only use it for COVID. When we're drawing FEMA and PRF dollars, it's only related to COVID.
But John, the net surplus that we're showing for the April year to date is not, it's not COVID-related surplus.
No,
That's surplus from all of our operations,
exactly.
right?
Okay, I think that's why I was
Yeah.
confused. I thought it was only related to the COVID. Okay,
Yeah.
now I understand better. Thank you. I appreciate the explanation. Thank you.
Thanks, Vinny. I think when you look at the two slides in isolation, we don't see the full picture. It's
Yeah.
sort of the first, this is showing the overall budgetary performance, and we are, the headline is, we are better than budget right now, year to date. But I think what this team did, which I thought was helpful, was to break down the components of, because we are, well above, not well above, but nicely above budget. And so to be able to see where those components are, what's driven by COVID and may not be recurring and continuing, so we can isolate as we're going forward, how we manage our budget and the ins and the outs.
And I think this is very helpful. I really like it. But maybe if we go to slide 6, if I can make a suggestion.
Sure.
I know I can do the math, but maybe there is a chart here that shows the net. How much is the net of the revenues and expenditure? And then you break down where the revenues are and then the expenditures.
Right.
It's a good point.
Yeah,
Yeah. I mean,
We'll do it on the diagram.
the 689 up top and the 419, right? Those are the two numbers derive the
Yeah.
270.
Well, the net budget is in the bullet. Maybe we just move that. See the 270 million, John? That's the net variance,
That's
right?
right. That's right.
Yeah.
Yeah, we can move it to the
Okay.
diagram on top as an overlay.
But thank
Yeah,
you.
and then you can just do it. Okay, that sounds good. I understand now. I'm sorry that I was a little bit confused with the COVID. I thought that this was only the COVID. So I understand.
No,
Thank you.
thank you.
Thanks.
We're hoping next year is going to be a lot easier. That's our
Yes.
hope.
Who knows with the new variant BA? Who knows?
Fingers crossed.
Hi, it's Barbara. I have a statement or question.
Yes, Fenioska, you're finished? No other questions? Okay, Barbara, please, go ahead.
Yeah, as I hear this, and I know how hard it is to put together these wonderful slides and such, but when I look at my past experiences, the nursing budget, which was always kind of mysterious because it didn't have a lot of legs. We have legs now. We have a staffing, new plans and such. I just want to ask John, in the next fiscal year, how well do you think we will do as well as we've done so far on the staffing side, the clinical staffing side, or are we going to have, well, I guess it depends on how many more COVID events emerge, or do you think we're going to still hold solid with this?
Yeah.
And I know we have new mandates for staffing control from the, at the state level.
Yeah, no, I appreciate that. I mean, I think we're very proud of the fact that we actually do for inpatient services and we're building it for the other nursing related services, but we have a staffing model and we've embedded that into the organization. So every month we're looking at how many beds were filled versus how many staff did we have, and of those staff, how many were full-time, part-time, how many were temp, how many were overtime. And again, our goal is to always make sure that there's enough resources at the bedside, right, to meet the staffing ratio, to meet the patient care. And I think last year we did a pretty good job at that. I mean, I think if you were to look back, right, with the assistance of the temp nurses, right, because our nurses got sick, but even with the assistance of the temp nurses, we believe on average we always had enough nurses at the bedside. It wasn't always easy. So I feel pretty good about that, and we'll continue to build out these models. And we'll report back, right? The nice thing about the models is that we can see the data and report our results.
Well, John, do you look at this from a unit or service level for nursing as well?
Yes, our models go all the way down to the unit or the bedside.
That's very important. I saw that model in full bloom in the state of Massachusetts years ago, and I was so jealous that we didn't have that.
We'd be happy to show it to you. Yes, I mean we've been working hard at it.
It would be lovely.
Yes. Yes.
I'd love to see it if that's feasible.
Sure.
Okay.
Absolutely.
Thanks.
Thanks, Barbara. Patricia Martone, Dr. Martone, do you have questions or comments?
No questions, no comments.
Great, thank you. So just before we move on, I did want to, on the staffing, since we were looking at that slide, the workforce plans that was referenced there, John, that is tied to the new way we're working with our affiliates. Is that right?
That's correct.
Trying to.
That is correct, and we're getting very close, you know, with PAGNI in terms of the development of the workforce plan, and we're well underway with both NYU and Sinai. So yes, that continues to advance, and from that, you know, we're going to develop the budget. But yeah, that's a lot of good work going on there.
Okay, great. Could we just go back to the VBP, that maybe the next slide on the value-based payment performance, because I did want to spend a little bit of time here since it is something very important, and we're having a lot of success, and it is helping us drive a lot of our strategic initiatives. What on the surplus, which is I think the top chart, do you have this down sort of in more granular detail as to what's contributing to the growing risk premium? Is that sort of complexities? I guess what I'm trying to get at is some of this due to what was happening with COVID, and will we start to see this coming down? So I noted in the appendix slide that the CMI has come down a little bit, and just trying to get some context for that very nice growing orange line in the risk premium.
Right. Well, I think there's essentially two factors to the risk premium increasing, right? One is just the number of members.
Okay.
Number of members on which we are collecting a premium and a capitation payment. And the other is the amount of premium per member. And there are many factors that go into the amount of premium per member. There's a lot of work that goes on making sure our CMI and our risk adjustment are captured appropriately, that members are enrolled in the specialized product that's right for them. And so I think that work of premium per member, I think we continue to anticipate seeing significant improvement in. The number of members, the rate of growth that we've seen since the public health emergency was put in place has been significant because there's been very limited redetermination and churn off of the Medicaid program. So that is when we have to watch very closely, and we're in conversations with our plan partners and with the state around how that's going to work, and how we can minimize the number of people who lose coverage as that happens. So of those two factors, I'd say we will work very hard and feel confident that we can keep our attributed membership up. We feel extremely confident that we will get our premium per member up, because that work is really just at the beginning stages, and we have a lot of room to grow there. But Marty, John, anything you'd want to add there as well?
No, I think that's it. I think, again, in particular for Medicaid, the state has a role when they set the premium, right? And then we know that they've always been at the bottom of the range, and they're trying to make efforts to get the premium where they set it a little bit higher in the range, which would help as well.
And the membership, Matt, you said was due. I mean, some of that might have, I think there was a note here somewhere that said it was partially due to the pause in Medicaid recertifications. Is that something that we might see, because is that ended? That's ended, right? Or
it is not ended.
Okay.
I think we are waiting for it to kind of kick into full speed, but it's something we're certainly going to be watching.
Right. But you don't anticipate, because of the other work that you're doing in terms of growing membership, we're hopeful that this is not going to be a blip, for example, that is going to come back down, right?
We're certainly hopeful. I mean, I think it will be tough to sustain the rate of growth that everyone has seen over the last few years, and there may be months of decline, but population growth and unfortunately changes in the economy and how people are moving into Medicaid. There are a lot of different factors there, but recertifications will certainly be a headwind to membership growth. There's no question about that. The degree of that, as John said, and we talked about, depends on the state, depends upon us and our health plan partners' work in recertifying members, helping them enroll, and the marketing and outreach for our key value-based health plan partners. So some of it is within our control, and we'll work as hard as we can to keep it from going down.
Okay, but so some of this discussion helps to put some focus on, I know we talk in strategic initiatives, also in your budget development strategy, a big key component is this work you're doing on the value-based pay care program. And so a lot of it is what you just talked about, membership growth, premium per member, keeping that, the different special populations, getting them into the right area. So just wanting to pull those two pieces together. Am I articulating that at least in
Absolutely.
ballpark accurately?
It's a growing part of our business. It feeds into a lot of different things we're trying to do. And I think the key part of it for us, given how committed we are to value-based payment as a system, is that it is not really in conflict with our other revenue growth strategies, right? Many systems look at it as a kind of either or between you're going to be successful in value-based payment by being efficient, or you're going to be effective in fee-for-service medicine by driving volume and improving your billing. We really have the opportunity to do both because of the scale of our commitment to value-based payment and the nature of our opportunities therein on risk adjustment and premium improvement. So it's a win-win-win for us, and we've had success on it so far, and we'll continue to do so.
Great.
I think that I know Metro Plus is being very cautious. They're, I think, projecting maybe a 30% drop in recertifications potentially, but they're also contacting members now to help to ensure that they have all the paperwork and stuff they need to be able to certify once this lull in recertification gets terminated.
Great. Thank you, Sally.
Yeah.
Just on the quality bonuses, Matt, that's, so I think as we've all talked about already, the Health First results statistics are really terrific. And we've often talked about it's hard to measure what we're doing, and that's clearly a key tool to help us see that success. Is there, these bonuses, do they translate into dollars, John or Matt, that we also track?
They definitely do. I think we have the Health First bonus payment on that slide. From memory, I think it's about 6.8 million this year.
Oh, I see it. I'm sorry.
For them. So that's a growth year over year. And that's great. We have a similar program in Metro Plus that reports a little bit later on in the year. So we'll come back to you with those results when they're done. But combined, they are a meaningful portion of our revenue. And I think the other side of it, we believe the higher the quality of the care, the more efficient we are, the less unnecessary hospitalizations and other things we have. So therefore we have, better management of that premium dollar and a higher surplus as well. That's harder to directly correlate to the quality measures, but that's the other side of the revenue picture that, this great performance on largely primary care and ambulatory care measures drives for us.
Okay, that would be interesting to see sort of the historical, if we start tracking that more regularly, how that's improving.
Yeah, I'll also
Absolutely.
mention that the state restored previous cuts, right, in the managed care quality pool
Okay.
for the plan. So that should trickle down to us. The plans, and we were very appreciative of this. The plans really advocated for those quality dollars to be restored, and that is the right thing to do for certain.
Terrific. Actually, one other question on the expense growth. That seems to, well, this is really just a question. On the blue, I'm sorry, it's the slide, 2 slides earlier. The growth on the expenses seems to have flattened a little bit in the last couple of quarters. Is that a trend, or is that nothing we can really read into?
I don't think we can read into it yet. I think, we are getting more sophisticated at how things like external referrals, our ambulatory care quality measures, and other things drive medical expenses. But I think, the swings in volume that we've seen and the swings in utilization of people staying away and our, shutdowns of ambulatory care, I think make it pretty tricky to trend this in a meaningful way, particularly with how much better our revenue cycle services have gotten and our, our overall revenue capture. So I think we got to get a little bit smarter on this before I can tell you a trend there. But I mean, you notice back in 2020 Q2, major drop off, right? That's the heart of the first COVID surge, just an unprecedented drop in medical expenses that if we were a purely fee-for-service based system would have been a devastating loss of revenue, right? It was still a major challenge, but the amount of value-based surplus we were able to collect based on that period, was a major stabilizing factor for us. And I think one of the major arguments that we've made and some others around the country have made in the importance of value-based payment for stabilizing the delivery system being a dependable revenue stream and a more reliable way to structure the healthcare delivery system than pure fee for service.
Right, that shows it very well, right there. Okay, thank you very much, Matt, John, and the team. I think this is. I'm glad we were finally able to have our full discussion on value-based pay. I have one last question for Test and Trace. I'm not sure.
I'm here, Frida.
Let me see.
Sarah.
Okay, great. You're in the room. Sorry.
That's okay.
Is that you mentioned Test to Treat, which I think is terrific, and obviously we've seen the wonderful discussion about that. And I just was curious about the financial estimates that you presented here. Is that it cover Test to Treat, or is this an outside of the T2 budget here?
Yeah, based on some other changes we've had within our FY23 projections, we expect this 197 million will cover the baseline 30 units for Test to Treat.
Okay.
Yeah.
Terrific. So that is covered in, and that's basically, is that only going to be Test to Treat?
So,
the 197?
Yeah, so for
So it's in the 143, basically.
That's right.
It's incorporated in the one.
Yeah,
Okay.
the 143 also includes our Gotham and acute testing sites, as well as summer school testing. It doesn't include any surge scenarios at this point, so that would have to be vetted with OMB and determined based on, what the testing needs are at the time.
Great. Thank you so much.
Yeah.
All right. Terrific. This has been a great update. Thank you, everyone, for the great comprehensive work and excellent results. And I think we now have an informational item from Linda DeHart on financing. Linda.
Thank you. So this information item is reporting on activity taken under previously approved authorizations, resolutions from the board authorizing equipment financing. So we wanted to provide some background on that authority. There were a series of resolutions passed in 2013 and 2015 through which the board authorized the CFO to borrow from time to time up to an aggregate amount of $120 million for equipment and related capital financing. The goal at the time was to allow the system to establish a flexible equipment financing program with access to capital funds as needed from time to time. So under this authority, on June 15th of this year, we entered into 2 agreements for loans with JP Morgan Chase Bank totaling $39.7 million, and we'll provide the detail of that transaction through this presentation. There have been 3 previous borrowings under this authority with combined outstanding balances of $22.9 million. And all of these agreements have been secured by a secondary lien on the system's healthcare system, health reimbursement revenue. In other words, this is secondary to the lien by the bondholders. Can move to the next slide. So some background on the reason for this transaction. In March of 2013, the board approved resolutions authorizing negotiation and execution of financing with New York Power Authority, or NYPA, to partially finance boiler replacement and energy efficiency projects at Elmhurst and Metropolitan. Those projects were substantially completed in 2018, and we entered into agreement with NYPA at that time for variable rate loans based on the initial value at substantial completion. The rate for that loan was reset annually based on NYPA's cost of borrowing. This past year, NYPA informed us that there was a change in their policy with respect to how they were managing their borrowing that would have affected the rate we were receiving on those loans, and we determined that it was in our best interest to seek competitive refinancing options. So in 2018, when we entered into the initial loans on substantial completion, the combined value was $44.3 million. We have had a remaining balance of $39.4 million at the time that we started to look at this refinancing, and there were a small amount of closeout costs related to final completion of those projects. So the net amount that we owed to NYPA was $39.7 million. Can move to the next slide. We, using our financial advisor, PFM, issued in February of 2020 to solicit bids for this refinancing and received proposals from Bank of America, JP Morgan Chase, Morgan Stanley, Siemens, and TD Bank. We subsequently selected JP Morgan as the lowest cost lender in April of 2022. We did approach both our H&H EEO office and asked PFM to do some review regarding MWBE bank capacity, and they found that there were no lenders with the capacity, no identified lenders with the capacity to do this financing. So we included in our RFP a requirement for proposers to disclose their recent diversity, equity, and inclusion policies as part of their response. And we have some highlights from JP Morgan. They created in 2020 a $30 billion commitment, including loans, equity, and direct funding, as a 5-year goal to address the racial wealth divide and to provide economic opportunity to underserved communities. They've reported as of October 21 that more than $13 billion of that commitment has been deployed. They also, in 2020, hired a new global head of DEI for an expanded function to create and execute a holistic internal and external strategy looking at diversity and how JP Morgan develops products and services, serves its clients, helps its communities, and supports employees. We also asked JP Morgan for information about their workforce demographics, and they report that as of March 22, 55% of the total US workforce and 25% of the US executive and senior level managers were non-white. Excuse me. And also as of March 22, 53% of the total global workforce and 33% of the global executive and senior level managers were women. Moving to the next slide. The terms of the agreement that we entered with JP Morgan are as follows. 2 15-year tax-exempt loans, which were executed on June 15th, 2022. $19.4 million for Elmhurst Hospital, $20.4 million for Metropolitan. They're both fully amortizing with final maturity in June 15th of 2037. They are at a fixed rate of 2.6436%, and that rate was locked in May prior to executing the loan, which turned out to be to our advantage. Cost of issuance for this financing was just over $74,000, so the total amount borrowed was $39.75 million. I'm happy to take any questions.
I'm on mute. All right, I'll thank you, Linda. I'll go through the members. Jose?
No questions, thank you.
Sally?
Oh, it's H&H that repays these loans?
Yes.
Okay. That's it.
Okay. Fenioski?
Thank you, Frida. Linda, I just want to go back to the MWBE question. And again, maybe Frida knows a lot more than what I about this than I do. But I think it's really great the information that you provided and the effort that JP Morgan is doing. But I know that this is not a lot of money. You know, we're talking about $39 million. This is not. But, you know, in a lot of financing deal, a lot of these big companies, they pull together. They don't do it all by themselves. Is there a way that when, and I don't know if we are going to go back to the market, but is there a way that we can put in our RFP ways that encourage them to pool with a minority MWB that will provide, you know, something like 30% of this, you know, like $9 million or $12 million. I don't know what you would think. And they can pull it because, you know, in a lot of the big deals, they come together and they work together. I know this is a small amount for this, but I don't know if there are any ways. I don't know, Frida, if you know anything like that, because this is your world. You may have more information.
Yeah, so I think, and Linda, you can correct me if I'm wrong, but I know that the team did do some research into looking for potential, because there are a lot of, you know, minority-owned banks and smaller banks who do financing. And I think in our experience, it's the size is one consideration. What is the size to be able to do it on their own? And then, Fenny, you bring a very valid point. There are a lot of syndicated deals where there are multiple banks that participate, and we have in. I know that there are banks that can join in that fashion. The challenge is often the return rate for the banks, and for the smaller banks, sometimes the return rate requirement is much higher. And so and I want to, you know, I'm very glad you guys locked in the rate in May of 2022 at 265 for a 15-year rate is very, very attractive. And so you can see, Fenny, that's a very probably, you know, lower hurdle rate on the bank side. And so, and in terms of timing, you know, I don't know what it would be today, Linda, if you've checked, but I would guess it's maybe a percentage point higher at least, just in the month and a half or so. So I think the challenge is that our, you know, the quality of our credit, for example, that would dictate a much lower rate. We got some very competitive rates, it sounds like, is often a stumbling block as well for having participation. But it is something that I think the team, as we go forward, we can try to, I know there are a lot of efforts underway to try to increase participation among minority-owned banks, and how can the industry work together, et cetera, and try to make sure that we meet the capital requirements and the investment return rates are can work in terms of, you know, what our need is and what they are able to provide.
I do agree. Again, I know that the amount of money is not large compared to what those syndicated deals are, but maybe there is a way, and I really don't know when we're going to go to the market, but maybe there is a way on the RFP to encourage those type of things and see how they can work it out. You know, the same way that they are investing in diversifying their portfolio, there may be ways to encourage them to work together with minority banks and, you know, giving a little bit on what they will gain and what the minority banks will gain. I think they can be very creative in how they put this syndicated type of loans, even a smaller scale like this one. And I think we just try to put it out there and float it to see if there are any opportunities.
Right. Yes, I think it's unfortunately the higher the rate or the risk on the risk spectrum, right, sometimes the easier it is, counterintuitively. But but I think it's definitely something that the team, and Linda, we've talked about that in terms of trying to find ways. So I think Penny will want to talk with you as well for ideas, and I think that's helpful.
And I
Hi.
just want to say thank you for getting the data of the demographics. I think this is very, very helpful. So I just want to commend you for
All
that.
right.
Okay.
Thank you. And
Linda, were you
Penny?
trying to say something? I'm sorry.
It's Barbara.
Oh,
Penny,
Barbara.
I think that's an admirable discussion you've raised, but you'd have to make that industry feel real comfortable that we have phenomenal control over cost because, you know, we're one industry that's pretty daunting with all that has occurred over the last few years. It makes it even more daunting. So it'll be great to get to work and helping build that opportunity for the smaller banks.
thank you. And
Thank
we,
you.
just wanted to say we appreciate that conversation as well, and we have broached this issue with Frida and planned time to talk about strategies to improve participation
Nice.
moving forward. Both I think in this area and more specifically per our past discussions with respect to our bond financing.
Frida, just one last comment. The data that they provided was the national data. Maybe it would be good if they can also provide the New York data because they have a big presence here. So
I actually do have the New
that
York
would be-
data. We didn't get it in time to include in the presentation. But as of, I believe this is also as of March, for New York, 54% of the total workforce was non-white and 50% female. Of the New York senior and executive level managers, 27% were non-white and 35% female.
Thank you. Again, if there is a presentation for the board, if you can add the New York data, that would be super.
We will, going forward.
Thank you.
Frida,
Great. Thank you.
Frida, just a quick comment.
Sure, Jose.
It's a great discussion. So maybe, like, especially if we look at local banks that operate in the communities that we serve, or, you know, I mean, I guess it's always New York City, right? So, but local banks that are in WBE that, I don't know how many are out there, but it sounds to me like even if their price, even if the interest rate they charge is, I don't know, 1/4% more or 0.5% more, that, I mean, that bank and their presence in our local communities makes a huge difference in terms of stable employment, so on. So the spillover effects for us are huge. So it would be interesting to find out more about that as a possibility.
Yeah, I think we can.
Well, good point. Sorry, Linda, go ahead.
I was just going to say we can talk more with our EEO office about that and sort of build that into some of this future conversation we want to have. They did identify 2 local MWBE banks, but the capacity was really just a fraction of what we were looking to borrow. I think it would have been difficult we really would have taken a lot of work to address this from, that syndicate idea or how they could partner with someone that we just didn't have the time to do now because the capacity was so small for those particular banks. But I think we certainly agree that it's worth exploring.
Thanks.
Right. Thank you. And all good suggestions. And I think there's a lot of opportunity here to try to be, as Penny puts it, creative and expansive and thinking how to make this work for everyone. Barbara, did you have any other questions, or I didn't know if we cut you off? No? Dr. Martone?
None,
Any
thank you.
questions?
I think this discussion was great. I was locked off. Sorry about that.
That's all right. I'm sorry, is Dr. Martone still there?
Yes, I responded. I said, no, thank you.
Oh, okay, great. Thank you very much. Sorry, I couldn't hear. Terrific. Well, thank you, everyone. I think this was a great meeting. If there's any old business, any new business, there being no further discussion, the meeting is adjourned. Thank you.